Everywhere it is written that major cause of hydrocele is high invagination of high tunica vaginalis. But
No, well, that's wrong. If it is written, then you better understand that's not the answer. That's not the reason. You see, now I think I'll take 5 minutes and you will understand everything. But PG would have benefited more. But the whole story starts with.
This is called landscape.
Tell me.
Yes.
So the whole story starts with. And even before, with the descent of testis. And even before, with the whole idea of the gonads to be put outside. So it starts as the descent is happening. Along with that, it drags her. What is taking it forward is gubernaculum, which is the guide. And what it does in the process, because this is all happening in the retroperitoneum, there is no peritoneum. But when it is just coming down, it takes a fold of peritoneum with it. Naturally, it will kind of, it's like this. And as it takes it down, this is the testicle, the fold of peritoneum is going like this. It continues to remain patent, only to close later on in such a way that some bit remains to cover the testicles, obliterates, and that's a deep ring, and the peritoneum is over. And this remains as a cord. Okay? Blood supply, everything is coming down, no? The blood supply, nerve supply, everything comes down. That's how development happens. Descent happens that way. So this remains here. See, nature is very, very clever. Now this is the tunica. To be पढ़ ले आ जाए. Vaginas. You know this.
yes, sir.
And this has got some fluid in it to serve as a buffer, protection. So this is the usual thing. This is normal. If it doesn't happen, what abnormalities can happen? It remains patent. What we call as triple PV, persistent patent processes vaginas. So, if there is fluid in it, some people will call it hydrocele. If there is content in it, they will call it hernia.
Yes, sir.
So, they use the term congenital hydrocele and congenital hernia. What?
Congenital hydrocele
and congenital hernia.
Congenital hernia. They are both wrong. So when you hear this term, you should understand that this person doesn't know about it. Why? Because it cannot be made out. So you are asked a question, how do you differentiate the two? Because then your answer would be, how do you differentiate between a congenital hernia and a congenital hydrocele, Kumar?
So you cannot say.
No, that I told you, but suppose I had not told you.
Cock impulse.
No, how would you differentiate between a hernia and a hydrocele? You can do transelimination. That's what you probably would say. But the problem with transelimination is that in children, the gut has got a very thin wall. So even that is transeliminated. There's fluid inside it. So it's a false positive or a negative
Yes, sir.
in infants. So this test won't help.
Yes, sir.
Okay?
Yes, sir.
How do you differentiate still if you're too fussy about it? Is that you lift up the scrotum, and if it is a solid content, it will reduce quickly, and if it is liquid, it will take a longer time.
Yes, sir.
What you see in the ink pots, which were there earlier. So ink pots, If you put them upside down, only a drop would come. But if it is full of sand, it will all start emptying. That's called the inverted ink pot sign.
Inverted.
So if you actually run into a fossil, he's asking you repeatedly, नहीं ये तो बताना पड़ेगा. तो ये test है. We therefore don't go by this. We call it all. This is a PPPV, and the treatment is herniatomy, not eversion of sac or anything else. Because in children, the inguinal canal is not yet formed. Why? Because there is no superficial and deep ring. वो नीचे अभी आई है. As the person is growing, the canal starts forming. It goes deep, this goes superficial. This becomes deep ring, this becomes superficial ring. Clear? So the obliquity of canal is maintained, deep to superficial thing is maintained. So you don't get hernia as you stand each time, no? Otherwise the contents will keep going down. So it's kind of adjusted in such a way the rings don't overlap, and then their depth is different. So the contents it'll block itself, and then there are arching fibers or fibers of internal oblique. There are many factors. So therefore the contents don't just go down. When this fails, hernia would happen. So congenital hydrocele, you are asked a question here, MCQ. The answer is eversion of sac, aspiration, herniatomy, and something else. You would say herniatomy, hydrocele का थोड़ी होगा, तो आप उसको टिक नहीं करते. That's a mistake. The answer is herniatomy only because there is only one ring where you just dissect the sac, empty it, do the herniatomy. Connection is gone. So that's your first type of confusion. The second, it remains patent till about the deep ring, and a little above the testis. So it kind of assumes superficial ring, sorry. So it looks like a funnel. So we call it funicle. Third is, it is obliterated completely. There is only a central part which is in the scrotum which remains patent. We call it encysted hydrocele of the cord. This is the only swelling in the scrotum where testis can be felt separately. Otherwise, in all scrotal swellings, the testis cannot be felt separately, and you know the reason. Here, the testis, if you pull the testis, it gets pulled. That's a test you do. Testis pull test, as they call it. And there's one more, which is called infantile, where it is all obliterated up to the superficial ring, but below that it remains patent. There are 4 types which I have told you. What did you ask? High investment.
Sir, यहाँ भी question. Sir, ESDAS, it is written in ESDAS that we can get above the swelling in case of all except infantile hernia, infantile hydrocele. Sir, मतलब ideal found correlation. Sir, in congenital also there was.
You can't get above. गलत है.
अच्छा, ओके.
मतलब तू खुद ही देख ले. तू लिख ले दास. ये है, इसमें कहाँ से अबाव जाएगा तुझे?
Yes sir, वही sir I want to clear that.
ये क्लियर ही है. इसको और क्लियर कितना करेंगे? ये गायब हो जाएगा. जो चीज़ें हैं वो है. इसमें कोई आर्गुमेंट थोड़ी हो किताब में लिखा है. उसमें यह गलत इंटरप्रिटेशन हो सकता है. Forget that. हाई इन्वेस्टमेंट की जो बात थी ना, उसकी इंपॉर्टेंस है. हाई इन्वेस्टमेंट ऑफ ट्यूनिका, also called as bell clapper testis. You seen a bell clapper? पुराने ज़माने में होता था, स्कूल्स में. नहीं, अभी भी होता. Or in the temples you find, or the railway station used to have it. There's a clapper and there's a string attached to it. So उसको हिलाते तो वो it hits, आवाज़ आती है. The bell clapper testis is Usually, if you just now saw, this is how the testis is covered by tunica. So it cannot undergo torsion. It can't, because torsion of testis is not torsion of testis, it's
Cord.
torsion of cord. But if this tunica was to go and get attached here, which is high investment, you follow what I'm saying?
Yes, sir.
So then it will become like bell clapper, no?
Bell clapper testis.
It can rotate within. This was keeping it fixed here, no?
Yes,
But it
sir.
can rotate within, and there will be torsion.
Torsion.
High investment का torsion से link है.
Yes, sir.
Got it?
Yes, sir.
Yes, sir.
And which is the direction? ये भी इस पे डिपेंड करता है. Torsion happens in which direction?
Opening the
Outwards.
Opening the book. ये तो रोहन ने फिर रोहन ने बताया. Very good. Going outwards. Torsion happens as the book opens, and you treat it by closing the book. So anti-clockwise on one side, clockwise on the other side. They go outwards. For torsion, they go outwards, and this has got to do with the attachment with the cord and the position of tunica.
Yes, sir.
This side is heavy, so it rotates this side.
Yes, sir.
The torsion will happen, yes, outwards. If this is the midline, the torsion will happen this way, outwards. Therefore, you look for, when the torsion happens, you look for the various signs. One is the angels, second is prehensile sign. Angel sign is that the affected testis is higher than the other side. Why? Like वो झूले में बैठते ना, swing, you keep going, no? पूरा उसको fold करके करके ऊपर भी जाते हो.
Yes, sir.
Then you come down.
Yes,
Yes, sir.
You remember that?
Yes,
yes.
There's something you do, but then your feet won't come down. Initially you start doing it, तो पैर से आप कर पाते. You are able to touch the ground. You keep rotating. After some time you can't touch it. Then you automatically unwind, and then that becomes your play.
Yes, sir.
That affected testis would obviously go higher because the cord has undergone the torsion. Prain sign is if there was basically you're differentiating it from another acute scrotal emergency, which is epidermal that occurs in slightly
Elderly.
older people.
Yes, sir.
This occurs in young teenage boys. So they may have epidermal where the testis would be heavier, more painful, and when you lift up the scrotum or the testis, the pain is relieved because you are relieving the edema.
Traction.
But in torsion, it's like somebody came and gave it a few more twists by lifting it up. So that is, when you lift up the torsion, the pain would get a little worse. But in pain,
Yes, sir. Yes, sir.
so that's the significance of high investment. It has nothing to do with hydrocele. The concept of back to the normal situation, this is the tunica vaginalis, this is the testis. Therefore, we call it vaginal hydrocele.
Vaginal hydro.
Otherwise, somebody may argue, no?
On the front sexes.
This is happening, and again, this vaginal hydrocele is primary and secondary. Primary, like where we don't know the cause or you're an idiot, that is idiopathic. Why don't you know it? So that's why they made it idiotic. So idiopathic. So there also there is a cause. And they found it is filarial in most cases. So it's not idiopathic. And importantly, what you don't know doesn't mean doesn't exist.
Yes, sir.
Otherwise, there's a big question about does God exist? You keep asking, I don't know, I can't see. I only believe what I see. But you don't see electrons, you believe they're there. You don't see electricity, but it is there.
Yes, sir.
So your seeing is not the end of the world. You're just tiny little dot in the whole scheme, and you can't see, so it doesn't exist as being foolish. So primary is where the whole purpose is just look at two membranes. I think I taught you the other day. There is a secretory surface and absorptive surface. Either there is excessive production or there is reduced absorption or both.
Yes, sir.
If there is excessive production, it can be due to various causes, secondary causes. You know, they are tumor,
Tuberculosis, infection.
tuberculosis,
Infections.
infections and malignancy. Tumor हो गया ना. ये ऐसे होता है, बढ़ाते जाते हैं ना वो 10 cause बनाते हैं. Trauma, tumor, trauma, infections, parasitic and bacterial. Parasitic is filarial, bacterial, acute, chronic. Acute is epidermolysis, E. coli. Chronic is tuberculosis. Rarely leprosy. Finished? Oh yeah. And then malignancy, etc., 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 etc. So, excessive production. Yeah. Poor absorption is a possibility. Now, both are a possibility too. So, the treatment is eversion. We just open it, drain the fluid, and we evert it. And I give you the example of Jarasan
Yes, sir.
and the fight between Bhima and Jarasan. And each time he'll split him and throw, they will join and become one. So then Lord Krishna said, this way. So they did put it this way. That's what the treatment is. The treatment of Jarasan is the treatment of vaginal adversity, eversion of sac. And all these fancy terms like jabolis, eversion, Lord's plication. Lord's plication is the same thing. You opened up the sac, opened it, fluid came out, you pushed the testis up. Now you everted it already, but you want to keep it there. So you do pleating by putting sutures, pleating. So it becomes like a flower all around. That's done for relatively smaller adversities. Okay?
Yes, sir.
Standard drill is you stabilize with these two and use these two. Or you stabilize with these two, then you use these two only. But it is better to stabilize with the lower fingers and use these two. This is what I have taught him. I am sure he must have taught you the same.
Yes.
Okay?
Yes.
Ma'am, I wanted to ask if the torch is supposed to be shown medially and we need to check for transillumination
now what
from
you-
lateral side.
No, ask the question. Yeah, please ask it.
If the torch is supposed to be shown on the medial side and we need to check for transillumination laterally, or is it the other way around, and is there any significance for it?
See now, this is the swelling. I have fixed it. I need to stabilize.
Yes.
If I put the torch here and see from the same side, I won't be able to see anything because I'll be blocking it. Although this is too light, too bright for you. So ideally, the others, you must have seen some people doing it from here. That is also acceptable, but you would get limited space. The ideal thing is, if there is testis there, that needs to be excluded out in your light, and then make it tense, as I have done just now, and try to see from the opposite side. What is this angle? 45. Okay?
Yes.
And it's a good idea to do it 2-3 times so that the eyes adjust. And what is floating is the testis, you can see.
Yes.
You believe it, that's amazing. So, that's the way to do it. Done?
Yes.
That indicates the fluid in it. The problem of doing, in this case it's too bright. The problem of doing it from the same side is how would you appreciate it if there is a small amount of fluid. Yeah? So, suppose this is the testis. You won't be able to appreciate. It's too bright for you. But if you put it against testis, see, I'm putting it against testis, it may block my light. Okay? So the best thing is to stabilize, fix it, use the torch from the other side and do it 2-3 times. Then settle down. You can actually see very clearly you can take it from top so that you get the idea of the testis. Clear?
Yes.
Tunica albuginea and tunica vaginalis are two different. Tunica vaginalis has 2 layers, secretory inside, absorptive also inside. and they are looking at each other. This secretes, this absorbs. This secretes, this absorbs. So the hydrocele can happen, this collection can happen if there is more secretion or there is less absorption, or both. Commonly both. So what do? I open it up. This was it, I opened it up and then I suture it reverse. So now they never see each other. It's typical of the mythological figure of Jarasandha. So Jarasandha had that Vardhan that you split him into two, he will join again. And Lord Krishna himself did not fight him. He got Bhima to do it. And each time Bhima will do everything and then tear him apart, throw him. They'll join again, he'll get up again and fight. It went on for many times. And then finally, Lord Krishna gives a small hint. He picks up a straw, breaks it, and does it like this. So now this time he does the same thing, but puts them the other way around. That is the inversion of sack. So they never join. And it is believed that he's still trying. So that's the concept of eversion of sac. Everted in such a way that it's the surface that was secreting and absorbing, they never look at each other ever again. So how is the fluid absorbed? By lymphatics. So you must always tell your patient that it's going to take some time before the swelling actually totally disappears. And sometimes you must have seen after surgery, the patient has a bigger swelling than the one he came with.
Yes, sir.
And then he says, I came with some hydrocele, yes. When I'm going with a bucket full of water, I came with a glass full of water. You have to tell him that it's going to take a little time. Unless it's a hematoma that you caused it. That's the concept. Clear?
Yes. Yes. Thank you, sir.